very briefly. And let's also let you know what is in the kitchen. Bone marrow is an old school now. We're talking about gene therapy and CAR T cells. So this has not been included in the guideline. So we need to, that's why the guideline will also be regularly updated. We're interacting now. This is more like an interaction section. We need to know what you people feel. And then later we'll go back to the guideline. When the second edition is coming up, we're going to have new new procedures and then also modify it to meet international standards. So I would just say that stem cell transplant, when you hear stem cell transplant, in the past, it was called bone marrow transplant because the only source where we can get stem cells as at then, 1957, was only from the bone marrow. So, but after that, the appropriate name is stem cell transplantation. Because when I did my first bone marrow transplant in 2011, a professor of surgery asked me who was the orthopedic surgeon that worked with me in theater. And I said I was alone with my fellow hematologists. And the next question he asked, how did you move the bone? How did you move the bone from the donor to the patient? And I said, sir, we do not move bone. We only collect pluripotent stem cells from the bone marrow and transplant to the patient. So currently it's stem cell transplant because you can get stem cells from so many sources now. We can mobilize your stem cells from the bone marrow into the peripheral blood film and harvest it with apheresis machine. We can collect stem cells from cord blood, the biological waste that you discard. We can collect stem cells now from the adipose tissue. When you go for liposuction, we can collect stem cells from there. Even recently, there are stem cells that have been found in menstrual flows from women. So the list is endless why we collect stem cells from everywhere. So the transplant is actually, we do stem cell transplant to either cure a disease or ameliorate it. Sometimes we just want to make the disease better, but most times we attempt to cure the disease. It started in 1937, but only Donald Thomas in 1957 was able to perfect the transplant, and so he got the Nobel Prize. Not that he was the one who started it, but he perfected it. And coincidentally, in 2012, the world recorded 1 million transplants worldwide. 1 million, only 1 million. From 1957 to 2012. Donald Thomas also passed away in 2012. But between 2012 and 2017, the world had even recorded over 700,000 transplants just within 2012 and 2017 to tell you how rapidly stem cell transplantation is currently ongoing. But surprisingly, only 2 to 3% of this transplant worldwide is done in the whole of Mediterranean and Africa put together. Only 2 to 3%. It's not far-fetched. A lot of problems. Setting up a transplant center in low and medium income country is like the head of a camel passing through the eye of a needle. My professor here is my teacher, knows my journey in 2011 to start bone marrow transplant in sub-Saharan Africa. Now, first transplant for sickle cell was by coincidence. A patient had blood cancer, had sickle cell. We did a transplant. The transplant was done for the patient. Leukemia cured. Suddenly, the patient's genotype changed from SS to the donor's genotype, just in 1984. And so it became possible to say, yes, we can do transplant with sickle cell by using bone marrow transplant. That was when we started doing transplant for sickle cell from 1984. Baswai et al. Performed the first transplant in 2011, and since then, we've been having several reported cases. Lagos joined the transplants in 2024. So you discover that from 2011 to 2024, we once wanted to have a monitoring group, a regulatory group. It didn't work because just had only one center. But currently we have 2 centers in Nigeria, Benin and Lagos. And the third center is right here in Abuja, the African Medical Center of Excellence, where we have the up-to-date equipment to start doing transplant from 2026 and also to start doing gene therapy and CAR T cells for the cure of malignancies. Next slide. So we have increasing transplants ongoing. I won't spend time in this because this is more like a lecture for, even HIV can be cured by stem cell transplant, but not approved by WHO. But if I have a patient that has HIV and has bone marrow failure, another indication, then I will do transplant using a donor that is CCR5 negative. You know, persons that are CCR5 negative do not have the receptor through which HIV penetrates CD4 cells. There is 1 out of 1,000 European that is CCR5 negative. We are doing that research in Nigeria now to find out how many of us are actually CCR5 negative. That was what was found in Gambia when the research was done, and they noticed that some prostitutes were not using condom, and they were sleeping even with HIV patients, and they were never HIV positive. The virus goes around, no receptors to penetrate the CD4 cells. They die a natural death. So if you do that transplant for a patient, the patient becomes cured for HIV and also cured for the primary indication. Next slide. So worldwide, transplant is being done now in many places. Nigeria is just 2 centers, as I mentioned, but currently Ghana has also joined the transplant. There's transplant in Ghana, there's transplant in Tanzania, there's transplant in Senegal, South Africa, and most parts of the North Africa. Next slide. So this to show the regions and the distribution. Next slide. Africa, we're doing both autologous now for multiple myeloma and other conditions. Next slide. Indications are endless. You know, when they talk about kidney transplant, it's just kidney transplant. But for stem cell transplant, indication is endless. We are doing transplant for both malignant and non-malignant diseases. And as I mentioned, stem cell transplant is like an old school now. When we come to the next one, I'm going to mention briefly before we go into the guidelines. It's gene therapy and CAR T-cell. Next slide. So the process of stem cell transplant is like this. And in setting up the guidelines, we took each of these items. Selection of our patients, pre-transplant preparation, conditioning regimen, stem cell collection, transplantation of stem cell, post-transplant care. All these items must have standard operating procedures. And because we've mentioned ethical issues, the major ethical issues in stem cell transplant is when you are using match unrelated donors. You know, we can use sibling donors. In Nigeria now, we have not done any match unrelated donor. Not because we cannot, but because of some drawbacks. We have been doing family typed donor. Even despite that, when we want to do a transplant for an underage, the law says that we must get ethical approval from the parents. If a donor also wants to donate, unlike a kidney transplant, we have donors below the age of 18. Our youngest donor in Benin is a 9-year-old boy. There are standards in collecting stem cells from those who are underage, but the parents must sign a consent. Because if the underage is the full match to the patient, then ethical approval is gotten from the parents of the child signing approval that the child should donate. And there are SOPs. You must not collect more than 20 mils per kg from the donor. And once you know that that limit is enough for you to do your transplant, we can actually collect stem cells from minors. Next slide. Now, I want to talk briefly about gene therapy. Gene therapy is an autologous transplant. It has not come up now in Nigeria, but we are very certain that by next year, the African Center of Medical Excellence will start doing gene therapy and CAR T cells. Gene therapy is autologous, meaning unlike stem cell transplant, where we take stem cells from one person and use it for another person or use the same, you can now take the person's own stem cells and manipulate it. Manipulation means that, for example, a sickle cell, there's a position 6 in the globin chain where an amino acid is missing. So normally we all have glutamic acid in position 6. Sickle cell have valine replacing glutamic acid in position 6. So what gene therapy does is that we have been able to find a virus that will change that position 6 and move glutamic acid back to that position 6 and removing valine. Once we do that, we take the stem cells back into the patient, and then the patient becomes automatically AA. That is gene therapy. You don't need a donor, you don't need anything. It started with about $5 million in US, but right now it has come down to about $2 million. Well, $2 million to a Nigerian is like breaking the bank, isn't it? So, but the price is coming down now because the patency right is almost over, and then many researches are going on to be able to do gene therapy. So, but many centers are already involved in the research. Uganda, Tanzania, South Africa, but the African Medical Center of Excellence is already the only center now getting involved in gene therapy, so that by next year we'll start doing gene therapy. Next slide. The next one is what we call cellular weapons. This is what we call CAR T cells. It's called chimeric antigenic receptors. What we do in this is that when you have a cancer, for example, and the cancer is targeted as CD19 positive, for example, or CD20. We take your stem cells, take it to a manipulation center or manipulation machine, program your stem cells to have weapons against CD20, and then return the stem cells back to you. And the stem cells now in your body becomes a weaponized machine to kill any cell that is CD20 positive. That's what is called CAR-T cell. So it's called chimeric antigenic receptors. Next slide. Now, areas covered by the committee. Donor registry. I want to let us know that we already have a donor registry in Nigeria. That donor registry was founded by a Nigerian who had acute leukemia and needed a donor to get transplants. But they searched the whole of America, Europe, they didn't find a donor. They came back to us in Nigeria, we started looking for donors, searched all his family members, no donor. The young man finally got cured by cord blood. 2 cord bloods were put together and he was cured. After he was cured, he chose to set up a registry in Nigeria. That registry is being funded by the young man, and we have less than 1,000 volunteers. It's not difficult that because of the volunteers, it's because the cost of running the HLA typing is very expensive. It costs close to 500,000 to do HLA typing. So nobody will come and pay 500,000 to volunteer. It has to be paid for. So the registry is there, and we have guidelines setting up the registry. The plan is that the Nigerian Blood Transfusion Services, now Nigerian Blood Transfusion Authority, plans to take over that registry so that we can use it for all the registries in terms of donor registry, bone marrow registry, and if we want, we can also use it to do for other organ registry. But it's a government arm, and they are funded to be able to do that. So, but also too, donation must be voluntary. For match unrelated donor, it must be voluntary. I like to face reality. Even blood transfusion in Africa, in most developing countries, we all know that it should be voluntary, isn't it? But we also know that a man who has not eaten cannot donate blood for you, isn't it? So it is possible to get donations voluntary, but as mentioned, it has to remain voluntary. And then all we need to do is to pay for that. Those has been long overflowed, so I don't want to. Ethical approval. Consent must be sorted from donors. And then we're also hoping that international best practice must be followed. Now, in setting up a transplant center, the rules are there. If you look at the books, we put guidelines. I don't want to go through all that, but if you want to set up a transplant center, you need to have a director. Those are minimum standards. That's why we say we must start from somewhere. So we want to say that, oh, you're starting up a center. Who is the director of the center? Is he a properly trained person? Do they have nurses? Do they have doctors who are well trained? So there are stipulations of how they should be trained. Next slide. That's for the registry. For the transplant center, you must also have specifications. We've laid down specifications in this book on how the transplant center must be set up. Okay? And also, too, there must be evidence of SOPs. There must be ethical approval. The director also must be somebody who is a hematologist, an oncologist, or a pediatrician that must have at least 6 months training. This will be certified by the group when we're going around to say that this is a center that is supposed to be accredited. Next slide. Now, the challenges. These are one of my last few slides. More centers need to be opened. That's the truth about it. I was trained in Switzerland. Switzerland has a population of about 8 million, which is not bigger than Edo State. But that 8 million, they have over 12 transplant centers. Nigeria has over 220 or 250 million. We don't even know the exact figure. But we do not have more than 2 centers that does transplant. The same with kidney transplant. The same with radiotherapy center. Outside the country, HLA typing. But right now, we're trying to bridge the gap. Afreximbank has put up so much money in African Medical Center of Excellence. 5 will be built in Africa. They just started with Nigeria. Next one is Cameroon, then Tanzania. This center is equipped with the high caliber of equipment. So when the center is done by next year, no samples or tests will be sent out. We have a cyclotron that produces cyclotrons for PET CT scan that will be distributed across Africa. So we're hoping that the diagnostic problem will be over in terms of sending samples outside the country when the center becomes. Then funding is a big problem. I've told people before that the solution to Nigeria's health problem is insurance. Once we get our insurance right with a population of over 250 million people, we will be better off as a country in terms of healthcare. Now, next slide. So I just want to show some few pictures of people who are smiling. You know, sickle cell patients are always, they call them warriors. And when they get transplanted, they smile. Next slide. These are all our transplant patients. Next slide. Next slide. Multiple myeloma patients. Finally, I want to acknowledge the University of Benin Teaching Hospital for sending me for training. The hospital I was trained in Switzerland, the African Medical Center where I'm currently working, and especially the federal government, the Ministry of Health, and my teacher who has set up this committee to ensure that we follow guidelines and principles in management. Thank you all.
I asked you to reach before, so you'll be strong. Don't fall down.
Wow, can we please give a resounding round of applause for Prof. Professor Godwin, you took us to class. You brought us back. If you're back from reality, I mean, still stem plant transplantation. It's no longer known as the bone marrow transplantation, but now stem cell. Such a insight. But Prof, before we go on to questions, do you have an addition or a subtraction or what? Like to-
Well, I just want to congratulate Professor Bazwai. Can we clap for him again? Um, he's somebody who is not afraid of any battle, and that's why he ended up with a battle and warrior. Because I know, as a Lone Ranger, how he fought in Benin to carry out, always meeting with obstacles, obstacles, obstacles. And I want to appeal to all of you, you have get to a stage where you become a head of an institution, this and that. Support ones who are growing up. It's to your credit. If somebody in your institution wants to do this and is moving ahead, support him. It is an honor to your institution. It is in the interest of the people. It's not for him alone because it's going to leave the place. So I know how he battled and battled and battled and battled and battled to the extent he had to leave a place one time, go to this. But in growing up, in doing all this, he took people along. I know he took nurses, he took pediatricians, took them along to Switzerland to train them. He was building a team. And that is why he's what he is today. He has continued to battle to get into new lands, do all this and that is why he has succeeded. Now, you can imagine 2011, and we're in
Wow.
2025 now. Only a year ago, another center in the whole of Nigeria has just joined. You know? So I think we have to encourage each other. Stem cell is so important. For me as pediatrician, when we were in Saudi, that was when I first saw it, bone marrow transplantation, they were calling it that time. You know, and you know how many sick class we have. Not to talk of leukemia, multiple myeloma, it's something, and it says now you can even get stem cell from everywhere. Although not from the potato chips you had just now. But it's telling us that we don't call it bone marrow again, stem cells. Can get it from anywhere. So I think all of us should try. Let us widen the scope. Let us support each other so that it will be better for the country. Once again, I think I want you to please clap for me. So, okay.
And here's to more strides at the African Medical Center of Excellence. I'm sure you'll be championing medical strides. Thank you so very much, Professor Godwin, for this very insightful session. We appreciate you as always. At this hour, we're moving on now swiftly to the next speaker. We've had him here, but when something is good, it seems like you ask for more, just like Oliver Twist.
Sorry,
So,
sorry.
Prof, yes.
You want to ask questions later?
Oh, we have questions. I would like us to go
Comments?
for the session, and then we just have both, if that's okay. Is that okay? Okay, so we can save time. So we will have at this hour again for the second time, Professor Abubakar. He'll be here to take us on The next session, if you turn to the program agenda, you see that it's on guidelines for corneal gamete and embryo donation, storage, and surrogacy in Nigeria. Professor Abubakar Ayani for the second time. And then we'll have questions to cover for him and Professor Godwin. Yes, sir.
Gamete, embryo. It's after that, this one.
I want to acknowledge at this hour the Nigerian Medical Association, Abuja. The chairman, Dr. Emeka Anyogu, is with us. NMA Abuja. Dr. Emeka, can we see you with a wave? Oh, that is the chair. NMA, that's the Nigerian Medical Association, Abuja. Thank you so much, Dr. Emeka. All right, now.
Good afternoon once again. The chairman, distinguished Nigerians, NMA chair, FCT, ladies and gentlemen. So we are going to look at gamete, embryo donations and storage, as well as surrogacy. Next. I don't have any interest to declare, but I'm interested in improve medical care, education, and research. So once again, I have to thank the federal government of Nigeria and the Federal Minister of Health and Social Welfare, the National Tertiary Health Institution Standard Committee, as well as the Clarion Core Care Foundation for making this meeting possible. Next. The assisted reproductive technology use has been rising since 1989. There was, I don't know, Giwa Osage, that pioneer, I think in University of Benin, pioneered this procedure. And then more than 150 facilities are already doing that procedure in Nigeria currently. Most of them are in private. Then all along, regulation of that practice has been inadequate. The Lagos state government, they have codified the regulation. But like we mentioned in the morning, since March this year, the federal government has codified the framework for the entire country. Next one. Coordination body, Federal Minister of Health. Then we have National Assisted Reproductive Technology and Transplant Authority. Then collaboration, National Health Research Committee, Medical and Dental Council of Nigeria, Pharmaceutical Council of Nigeria, Medical Laboratories Science Council of Nigeria, and then the state government, among others. They are in charge of licensing, inspection, registry, and then to document adverse events that may have arisen from that procedure. Their core functions as display. Next slide. Then what does it take to licensing a facility to be doing that assisted reproductive technology? So the license categories as already displayed. It may be in form of the clinic, or it may be a tissue establishment. It can be surrogacy. A facility may be licensed. Then it can be comprehensive. Comprehensive, it means that it encompasses the aforementioned. Minimum standard, there must be people who are already trained, qualified people, especially gynecologists to lead the team. Then you have others like embryologists. Then they must have standard operation guideline, as well as material, like a crowd storage facility. Then, before they start the running of that place, there must be inspection to license, and then there should be renewal every 2 years. That inspection is supposed to be unannounced so that they can see them in action. What do they have? Term of manpower and then resource. Next. Then ethical issues in donated gametes. Gametes can be egg from the woman or spermatozoa from the man. Then we have what is known as compensation and commodification. Just like we discussed in the morning, the compensation should take care of, all those things that we too know that whoever is donating that egg or sperm will need. If the person need to be flown, maybe from Lagos to Abuja, that compensation to take care of it. If it require that. If it require that, that person should be lodged in hotel. I'm just giving example. But having said that, when we go down, we will see what the committee for gametes and embryo donation and storage with surrogacy. We'll see the amount they recommend for Nigeria. Then anonymity. This anonymity, maybe we'll discuss it later. Because a child supposed to know his parents. Then confidentiality. We have funny people in this part of the world. You may discover that I'm just giving it a professional involved in this. That person will now be talking maybe to his spouse or our spouse. Somebody came to know. Healthcare professionals will not do that. There should be confidentiality and privacy of whoever come to donate what. Then repetitive donor and age limit for mothers. Like in the document already codified, a woman should not donate egg more than 3 times in her lifetime. For men, they can donate as much as possible. Then the core principle, autonomy, benefit, non-malignant, veracity, and fidelity. Core principle of ethics must be observed. Next. Okay. Minimum personnel required if you want to establish assisted reproductive facility is as already itemized. Gynecology, embryo reproductive endocrinologist, sonologist is specific training in ovarian cycle so that you can know all those changes during the cycle. A fertility nurse, counselor, psychologist, because it's very, very important that a counselor should be able to counsel whoever is going to donate and whoever is going to receive, especially surrogates. We are getting there. Then specialists in crowd preservation and gamete biology. Next. Okay, we have talked of the personnel. This is facility. What are the material? Infertility diagnosis, semen analysis, karyotyping, sperm function. Female infertility diagnosis, endocrine assay, sonography, karyotyping too. Then therapeutic, ovulation induction, in vitro fertilization, intrauterine, then crowd preservation, accreditation scope. Okay, next one. All those ones, they are already documented in that book. Then all this one are what whoever is establishing that facility should provide. Next. Then indication for donor egg. Before somebody will qualify to receive donor egg, because it's not a frivolous procedure. Maybe the person has reached menopause, or they have removed the ovary, the gonads of that woman. If the woman has poor egg reserve or quality, maybe because of age, because of chemotherapy or radiotherapy, or the woman has autoimmune disease, then congenital absence of oocytes. Customer. You know, some people they go, maybe they do intelligence selection, color selection, then height selection. All those things, they are unethical. Yeah, designer babies. Thank you. Reimbursement. So what it cover for time? Because somebody who is coming to donate, you can calculate, okay, how much do you make if you go to work? If you go to your shop, how much do you make in a day? Discomfort, then lost earnings. All those, you can factor it in calculating how much you are going to reimburse the person. It's not like a compensation. You can't pay. And ethically, you must not pay for the donation. And then it should not be exploitative. You don't pay that money that the donor is, like you are exploiting the donor. Or the money should not look as if you are inducing something. Somebody that ordinarily will not want to donate, when he sees big money, then that is what the committee recommends, between 200,000 to 300,000 for egg donor. And then this one is not based on number or quality of eggs. Once somebody donates, in Nigeria, you can pay that person. Next one, for sperm donation, somebody can receive, a couple rather, can receive sperm, donated sperm. If the man has azoospermia, or he has ejaculatory dysfunction, or they have done IVF, there is repeated failure, or they are having genetic disorder that they know that the child can inherit. But we are discussing this with sensitivity to religion in Nigeria. So maybe if you have questions, we can look at it during question and answer period. Then the donors, male donors will be between 21 to 40 years. You know, there is certain age that when you get the semen at that age, you see all funny sperm cells. So maybe that's why that age limit is 40. Then sperm frozen and quarantine for 6 months. You know the reason for this? Usually, when they take sperm from the donor, they don't now go immediately to use it for in vitro fertilization. The reason is this: they would like to do another test. All the tests they have done for the donor, especially those ones that border on infective transmission of infective agents like HIV, you know all those conditions. They will want to repeat it after 6 months to see whether that person is incubating all those conditions. But they will have frozen the sperm. So it is after that 6 months, they will now use that sperm, something like that. Then compensation. A man is entitled to 30,000 naira per donation in Nigeria. That is the recommendation of the committee. Let's try to see. So, like we mentioned, before, usually the recipient is don't, like I mentioned, donor tissue is not a frivolous thing. There must be very clear indication before there must be the couple, they must consent to the procedure. Then you must have evaluated the psychological state of the couple, even the donor. That's why clinical psychology or psychiatrists, they're supposed to be among the team. Then usually, the person, the woman, in the woman part of the couple, supposed not to be more than 54 years. The reason is that a Nigerian lifespan, I think, is around 54. So we don't want somebody to deliver baby and not be available to take care of that baby. So that baby will not have disorganized life right away from the birth. Okay, next. Other guidelines. You know, in Nigeria, lesbianism, gay is outlawed. It's unfortunate because as student of ethics, we're supposed not to do that, but there's nothing I can do about that. Nigeria say it doesn't want same-sex marriage. So if you have facility, don't offer couple, gay couple or lesbian couple, don't offer them assisted reproductive services. If you do it and you are caught, then you know, when people come to your facility that, okay, they want assisted reproductive services, maybe you have gotten the egg, you've taken the sperm of the man, egg of the woman, you have fertilized them in the test tube. You know, you may end up producing more zygotes than they need. Or the zygotes have developed into embryo. You may have more than what you need for that couple. That is excess embryo. On no account, so you now give it to people who need it without the consent of the couple. Then the other thing is that there must be strict documentation. That man, you know, we talk of anonymity. That man that donates his egg is sperm, or the woman that donated the egg, you must document their details, even when you don't allow it to be known by the public or third party. Because in future, when the baby grow, the baby may want to know their parents. It's part of ethics. That baby, in fact, when we are only that, we cannot be discussing all the ethical part. That's transplantation is unethical. And based on the fact that, okay, now let's say you remove the testicle of a man and you transplant another testicle. All the sperm that is coming from that man is not his. So next, embryo donation. I know we know the difference between gametes, eggs, zygotes, embryo, fetus. Just like I mentioned, embryo, I think by week 7, you have embryo. But once it's more than that, you will have seen all the normal physical feature of a human being, and you say it's fetus that time. So embryo donation now. So there must be consent of the owner of that embryo, even if it is excess. Then you don't go and donate. Maybe a couple just go, not that they want to have conception. They go and donate, and the assisted reproductive facility now grow that embryo just for donation. No, there's nothing like that. Don't do that kind of. Then thorough counseling. Okay. Next, surrogacy. You know, you have commissioning couple. Then you have third party, usually a woman. The woman agree to carry the pregnancy to term and deliver the baby to the couple. So there are 2 types. There's what we call genetic. Okay, let's say you have a couple. The woman have issue having conception. Then the husband now, with the knowledge of the woman, will now agree to sleep with a woman, a surrogate woman now. That woman now will get pregnant and carry the baby to term. You know, the egg of that woman is part of that baby. That is genetic. Frankly speaking, the woman from the couple side is not part of that baby. It's not contributing. It's like that too. It's like there's a religious restriction in that. There's a religious restriction because the family line. So there's a religious restriction in that. But if your faith has no issue with it, you can go for it. That is how it is being practiced all over the world. In places, in climes where it is being done. But it's already in our, we have documented it, but it does not mean all of you must do it. Then the second one, which is gestational. Gestational, it is the egg and sperm of the couple that will be used. They are only using the uterus of the woman, the surrogate woman. to provide to just undergo that gestational period to bring that child to what? To term. And immediately that woman delivered the baby, he handed it over. So in that kind of surrogacy, it is normal. The baby belongs to the couple because it is their egg and their, there's what they call ecto-life. Ecto-life. They can they can fertilize the egg and the sperm in the test tube, and then they will now put that baby, maybe at zygote or embryo stage, in an artificial womb. But worldwide, I don't think it has received any approval. But it's possible. They will be feeding the baby through what they call growth pod. It's possible. I think as in Gahidi is the one that propounded that that's something. So it's possible now. There are some locations, some climes where they are having issue with women carrying pregnancy. The women they don't want to go through all this maternal something any longer, and their population is diminishing. Maybe those climes they may need it here, but not in Nigeria now. Okay, surrogacy may be used maybe when you have absent uterus. Maybe somebody did hysterectomy. The gynecologists are here. There's no indication for hysterectomy. Then recurrent miscarriages, failure of in vitro fertilization, and medical contraindication. There are certain disease conditions that if that woman carry pregnancy, that pregnancy will not be carried to term. Next. So guideline for surrogacy in Nigeria. If any woman is going to be a surrogate woman, her age should be between 25 to 35. Ideally, is supposed to have completed her family. Because a woman that is not yet having a child and is carrying a baby for another, she may renege. She may renege. For now, there is no surrogacy law in Nigeria. There's no surrogacy law in Nigeria. That woman may decide to say, no, I'm not releasing this baby. Because she has no child yet. So the woman must have at least 2 children or must have completed a family before you can now go to be carrying another baby for another couple. Then it should be altruistic, and then it should not be commercialized. Those are ethical guides. Then they need to actually counsel the woman as well as the couple. So the two of them, the couple, the commissioning couple, as well as the woman that is serving as surrogate, they must counsel them. Next. Okay, in conclusion, the federal government of Nigeria has codified and launched standard and guidelines on gametes and embryo donation, storage, and surrogacy for Nigeria. All of us as stakeholders, we have our individual and collective roles of getting acquainted and ensuring compliance to ethical assisted reproductive technology in Nigeria. Good afternoon.
Wow, Prof, you broke it down. Very interesting. Specific guidelines now and tailored for um, this that has to do with cornea, gamete, and embryo donation, storage, and surrogacy. I thought the gender advocates will revolt when they said a woman has the option of 3 donation 3 times, but the men can have multiple time. They can go as much as they want. I thought gender advocates say no. What is sauce for the goose is sauce for the gander. Do we have gender advocates in the building? Not in this regard. So you hear cases of the CEO of Telegram that we all use, the popular social app Telegram. There was a headline. He's birthed over 100 children. And I think this is where he plays. He's donated over 100 times. He's fathered over 100 children. So a woman doesn't have the choice or the option of having to do 200 if we want to compete now, because you're limited to 3. So very specific guidelines, age requirements, of course, choice versus ethics. A woman who isn't birthed a child doesn't even have the option or the choice. Someone was saying breach of contract. I heard some just behind. What if she's gone into a contract? Is it a breach? So these are the questions I'm sure a lot of people here will have to ask, Prof, if you don't mind. And when I heard 30,000 naira, I'm like, 30,000 naira? Sir, when you people were drawing these guidelines, 30K, I mean, can we, sorry, per visit, 30K times 100. Okay, like that. So if we have questions, if we have questions, but before we go into the questions, may I want to acknowledge the esteemed presence of a very respected professor here with us, respected nephrologist, Professor Mamven is here with us. Professor Mamven? Professor, he just stepped out. Oh, wow. Okay. So just to acknowledge that. So questions, Q&A quickly now. So for now we're taking 2 sessions. Remember Prof and of course Dr. Prof was also here, Professor Godwin. So we're taking 2 questions or questions to address the 2 sessions. So do we have anyone with questions? You're behind. Please step forward so we can see your face in the cameras. Yes. Just to let you know that we are streaming live across social platforms.
Sorry, before you go to that, I want to recognize once again the chairman of the NMA in Abuja. Um, I want him to give a word. We're in your territory, and we've told you you're going to get CPD credits, and it's the NMA that has obliged us. So that's why you're having a pre-test, post-test. I just called him, and he went around. He will say that he will make it possible, and not only make it possible, also come and say hello to us. So you are welcome. Please. Go ahead.
Yeah. Yeah. Good afternoon. Okay. Good afternoon. Permit me to recognize some persons. The president or the guest of honor, who is the president of Clarion Care Foundation, the chairman of National Tertiary Health Institution Standards Committee of Nigeria, the president of Professor Philip Epiodun, the guest speakers, of course, well known to me, Professor, a very renowned professor of ophthalmology, who is Professor Hani. And also permit me to recognize the DG HMB, FCDO, the president of Dr. Bello. I recognize you. And also other distinguished colleagues, ladies and gentlemen. I am delighted to be here, and I welcome all of you to this very gathering. There's no better time than this moment to discuss this issue, which is about how to promote ethical standards in organ transplant, as well as creating awareness, promoting the idea of doing it in a very proper way. So I want to thank the organizers and all the collaborators, and I'm sure we have some guests, and also the permanent secretary. I want to thank all of you who made our time to be here for this very important event. Nigeria is a very lawful country. We should also fashion ways to do things in a very standard way so that not be you do whatever you like. So I like this idea, and I want to encourage the organizers to please don't relent in getting message across. After here, I may also find another opportunity to do it elsewhere so that Nigeria will know what they should know about organ transplants, which of course is something cannot avoid. Let us look at the issue of IVF. It has helped so many couples who have lost hope in terms of getting a child. So it is a rare situation, but we should approach it toward the very needed ethical standards. And that's, I'm sure that's the aim of this. And also promoting the idea that it is necessary for us to know what to do. So I want to thank the organizers for this very idea, very innovation. It's very good. And I think God, just pray God will strengthen you to continue to send message across. On our part as NMA, which is a parents body of so many associations. All of us belong to NMA, apart from, yes, all the doctors. I want to assure you that we'll continue to collaborate. At any point you feel NMA has a role to play, which I'm already there playing, but that's sure that you'll not find us want to also give a helping hand. The message will continue to send the message across to members. Let us do it in a very proper way. Let us know that they need to consider transplants where necessary, but there should be some standards to observe. There should be ethical standards, and that's the message I feel we should go here with. Thank you once more. You're welcome to Abuja. Abuja is a very nice. After this, you should save time to go around. Abuja is a very beautiful city that everybody wants to be. So you're welcome. Thank you so much.
Thank you very much, Dr. Emeka Yogu. He is the chairman, Nigerian Medical Association Abuja. Goodwill remarks, and we want to say thank you for your continued partnership and collaboration. At this point now, we'll go to the Q&A. Yes, we have two sessions, Professor Godwin and of course, Professor Abubakar. So if you have questions, we have the first question here. I'll pass the mic over and then your name.
Thank you very much. Good afternoon. Good afternoon, everyone. My name, I am Rabi Audu, nurse from Nisa Premier Hospital. Nisa Premier Hospital. My question is on the area of oocyte donation. For the young ladies that voluntarily come for oocyte donation, and they have to come to like a center to donate, and then they go to another center and to another center. I want to find out what exactly are we doing to know that this particular lady has donated once, has donated twice, has donated for the fourth time, or third time, I mean. So is there any indicator for us to know such a person so that we can protect them as well? Maybe when they get married, they can maybe have some reservation for their own use. Thank you.
Do we take all the questions? Oh, Prof, I recognized you, but you stepped out. Yes, please, can we give it up one more time for a very respected nephrologist here based in Abuja, highly esteemed Professor.
Okay, just to build up on what she has said, I'm just wondering, like, if for the oocyte donation, do you get the eggs and store them? Like an anonymous a donor just comes, I want to donate eggs, and just store them for future use, or is it that if somebody wants to use the eggs, the person gets their own donor, just like we do in a kidney transplantation? I'm just wondering how. And then, Mr. Premier, do you give them compensation? Or how much do you give them?
Professor Mamben has a question for Nisa Premier. I'm sure the representative would respond to that. Do we have more questions? I don't know. I want people that have not asked at least before we come to you because you've had the opportunity. Is that fair? Please go ahead.
Good afternoon, everyone. My name is Norma Wokemba from NAPTIP. So my question is for transplantation in general. I hear a lot about ethical standards, but I want to know, are there any laws, any acts of National Assembly in place that regulates transplantation, both kidney, surrogacy? Because in NAPTIP, we have a provision where trafficking for organ transplanting is prohibited. Exploitation in general is prohibited. But beyond that, like deeper, shouldn't there be a law, or is there, maybe I'm not aware of it, an act of the National Assembly that regulates and, really takes care of transplantation? Because our hands are tied, kind of, if you can't really establish exploitation. Let's say maybe the person is well remunerated, well taken care of, exploitation becomes iffy. And but then we all know that it's wrong to pay for an organ. So is there any law, any bill in the offing?
Thank you very much. It's noted.
Good afternoon, everyone. My name is Oluchinwabi. I'm a nephrologist. I have two questions. When the second speaker talked about the designer babies, I'd like to know, do we have a way of disclosing identity of these gamete owners to the patient? Because I imagine that a child is born and then you don't know your parents, you don't know your origin. I don't think that is really ethically right. So I don't know. I would like to know more about that. Then the second thing is about transplant tourism. There are cases where we see, say, Caucasians coming to Nigeria with their own donors to have transplants done in our country. So do we have legislation guiding that as well? Thank you very much.
So do we have, okay.
Thank you very much. Thank you very much, Professor Bazai. That was an excellent presentation, and we appreciate what you're doing in the space of stem cell. But my question is directed to, yeah, my question is directed to Professor Abdulkabir. My name is Dr. Ashaulu. I'm consultant OBGYN and a minimal access surgeon with the Wuse District Hospital. So now that we have a lot of women getting into the older age group and still being single, and they're actually interested in having babies. They can afford it, they have the funds, but as part of your recipient's requirements, you said the couple must sign consent. So how do you cater for this in the guideline, where a single lady approaches you as a fertility expert and asks that I want to have a baby, is ready to give you a donor sperm? What is the position of the guideline as regards this? Thank you.
Thank you. Do we have any other question here before we proceed? You have a question? Comment? Okay. Okay.
Thank you. My name is Olugben Gabiru. I'm also a gynecologist. I'm also excited by the last presentation. And my question is in relation to what the last speaker said. Now, how do we preserve the normal family order or societal order when a single lady, because as one of the indications for gametes recipient is single lady. So when somebody who is single walks into your IVF clinic and demands that, look, I want, sperm or egg, they want to receive sperm, want to get pregnant, when that child grows up, and then begins to ask questions. Who is my father? So I think these are ethical issues that we must deal with. Thank you.
Okay, so we'll go straight to the responses from Prof.
Thank you.
Okay, Dr. James, yes, President Clarion Cole.
Yes, from so I guess this is in regards to the question of how do you track the donors. I think one of the tasks that the um, NTHISC is mandated to do is sort of a transplant registry, and that's something that Claricol, with our partners in the U.S., is going to try to help establish for the Nigerian transplantation programs. So I think this is where we can have a way to track such donors that go from center to center, not just for tissue, but also for organ, where there is a list of potential donors. So this is where I was talking about the people who are bringing those donors to your clinics, how we can pull them in and really have this list of potential donors that we can sort of reorient to do this in a more sort of legal and safe way. So that's something that is in the works. Obviously, it's going to take a lot of infrastructure between sort of, sort of aligning with the different transplant centers. So I think first steps first is, you identify the transplant centers that are actually able to transplant, that have the criteria to do transplant safely, and then generating a list from that. And then I don't know, it sounds like there's going to be a lot of little work, but we are starting to develop that framework.
Do you have okay? A first question for okay. So with regards to the stem cell transplant, I was wondering what's the maximum age, especially for sickle cell disease patients? Because before they would tell us that once the patient is maybe up to like 12, 13, 14, they shouldn't have a stem cell transplant. So has it been extended now to involve older people? Yeah, the age limit. Okay, so Prof, you
Okay. Good afternoon once again. In fact, I'm very, very happy with the interest from the questions. Serial donor. You know, the just like we mentioned that the standard 2025 standard is more or less like a legal document, but probably it has to pass through National Assembly. Some of them has to filter into the Nigerian Health Law, which 2014 to now. How many years is that? Because when this committee was sitting, before we produce the document, we have to also work in line with National Health Act. And then we honestly, there are some things that over time has overtaken them. Because if somebody, for instance, if somebody like blood products do some infraction, maybe just withdraw blood from a donor without consent, without indication, and then you now say such individual just pay 100,000, or he go for prison of less than 1 year. You know, in the implication of that, or combined, depending on the judge. You know, in the implication of that. So we were like, okay, all this money and the number of the period for imprisonment should be refilled. I'm starting there. But having said that, part 6 of that National Act is very, very clear about those things, how you can handle gametes, embryo. You can import or export gametes, no, embryo and zygotes across the border of Nigeria. If you do that, and you are caught and you are convicted, that's the word, you can go to jail for 5 years. No option of fine. I'm responding to one of us who asked question about whether we have regulation, NAPTIP. Okay? Then serial donor, it goes to NISA Prima to donate, is it egg or sperm? Go to, God know, another facility, donate. I think the first place where such individual goes to, we have, that is why all this clinical uh, tripod, clacking, good clacking is very, very important. Through your clacking, patient will reveal so many things to you. Eh? He's hiding, Abby. He's lying. Eh? It's not disclosing. Maybe, do we have radiologists here? Eh? Okay. 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 Let chairman say something on that.
Yes, I think part of what Dr. James was telling you is that the registry, which you say we want to start with, if the surgeons work together with us, somebody has mentioned NIN, this and that. In the registry, we're going to have list of donors. I'm going to develop a software. We spoke with a group from working with Dr. James and Dr. Obi in America yesterday. We're going to develop a software, or there's a software with which we can track them. Is that clear? So once they are registered, the donors, with that one, we're developing a software which we can track them. That was yesterday where we discussed it, just through the registry which we want to establish. Is that all right? Yeah. Pardon? Pardon? Well, or both. We are discussing. We are looking for ways. Some people are suggesting face, but yesterday, while we were discussing it with the colleague in America, one of us, I think, Larry Waju Adebayo, mentioned NIN or biometric. So, but the important thing is the registry, that you register whatever you are doing, and then we can do the tracking. If that person has been somewhere else again, is that right? Is that clear? Pardon? Protect whom?
Yeah. But okay, you know, we are students of ethics. We are students of ethics. When you are talking of confidentiality, there are exceptions. When you can break confidentiality, there are exceptions. When you can break confidentiality, you know, physician, primarily, prima facie, they swore to protect their patient or clients, even when they are dead. But there are exceptions. If you see that somebody is playing pranks and public interest is under threat, you can break confidentiality. How do you do that? Cancel whoever the patient that is involved, that this thing needs to be refilled. That is one. Two, if you now notice that your patient is not interested in cooperating, you know, many of us, we don't want to take or bend backward. There are magistrate court everywhere. Go to magistrate court, get court injunction that you want to. So if the person sue you, it will not have any effect. Then if the court requests you for information about such a client, you should disclose it. Those are ways you can break. Designer baby, like I mentioned, though I know there are a lot of things that are ongoing, even despite legislation. People should not take cocaine, do not take heroin. You know what the position of the law. But that does not mean people are not taking cocaine. That does not mean people are not trafficking cocaine. Only that if they are caught, they are on the wrong side of the law. Designer baby ethically is wrong. There's nowhere you go that you have any ethical clearance. How do you identify the donor? Just like I mentioned initially, the facility who provide that service must document the details about the donor. in case it is required in future. Either it's the baby that asks for it or the court that asks for it. I don't know whether I answered that question. Single lady asking for donated egg. Okay, donor sperm. You know, our family value is fast disappearing. But we can also stand our feet. When they say, when the West was saying that we should allow gay and lesbianism in Nigeria, did we allow it? And if Nigeria doesn't want it, you are getting on bet ethically, everybody has that right. But religiously, religion, you are getting what I'm saying. Just like I mentioned, religion recognizes that family line. So there are religion restriction that a single lady cannot just say, I want donor sperm. That is my response. Preservation, okay, society. Is there any other one that I've not? Is there any? Okay, Islam. Islam. No, Islam. You know, Islam doesn't
does it say that?
allow donor.
Where did it say that it's not allowed?
Excuse me.
Does the Bible speak about everything? I could give you so many examples of things that the Bible is silent on, but are not wrong. So what are you talking about? The fact that the Bible is silent on it 3,000 years ago, these issues were not on the table. Comparing homosexuality with a single person trying to have a child is not the same. I'm sorry. It's not the same. And it should be a personal preference.
See, let me be frank with you. The federal government has codified guidelines that will be following. All these guidelines may need to pass through the National Assembly. And then if it's later, as if the National Assembly passes it and assented to by the president, it becomes law. But for now, there are guidelines to guide your practice.
Okay, Prof. Prof has done just. Can we appreciate Prof? I mean, it's one thing to take his time, it's another thing to respond. Thank you so much, Prof, for your time and all that you have dished out here. Thank you so very much. Without further ado, for just a comment, we would like to invite Barrister Halita Adekunle. She is a group head and legal advisor of the NISA Medical Group. Please, with a round of applause, please, Abuja. Thank you. Please, can you come to the podium so we can have a clear view of you?
I don't think I want to take the space of the presenters. I just want to make a comment quickly. So, sorry, one house.
Can we please have, I know stakeholder engagement, you're engaging, but please can we?
So with regards to tracking, what has been, I recently made a presentation to the Association for Fertility and Reproductive Health in Nigeria, AFRH. And one of the things that I recommended was that you can create platforms, like 2 platforms. I don't know how the ICT people would like to do it, whereby there is a general platform where me, you, or anybody can go there and get information regarding surrogacy, egg donation. So basically, some of the guidelines that have been provided will be on that platform so that you know you have to be between 21 to 35 years before you can donate, and so on and so forth. Then, the second platform is the platform whereby hospitals will be registered on. So if, for example, I'm an egg donor, I go to NISA to say I want to donate my eggs, I'm registered on the platform with my NIN or whatever means of identification I'm to have. And then once I'm registered, it shows whether I've gone to Limi or Dida Hospital. I don't know if we know those hospitals. So that way we'll be able to track how many times that donor has been to that particular hospital. Unfortunately, we have issues where donors, especially the egg donors, you donate here, you've not really healed from the process. Some of them go through ovarian, OHSS, ovarian stimulation, is it syndrome or whatever. They've not completely healed, and then they quickly go because of the monetary compensation that is supposed to go to them. So our own advocacy is that we need to protect these young girls. They need to understand the implications of frequent donations continuously just for monetary gain. And the only way to do it is through this. Unfortunately, there was a speaker that asked, there was someone that asked about regulations. We don't have those regulations in Nigeria. Most clinics, apart from the AFRH, that has tried to come up with its own guidelines and which regulates in a way hospitals registered under it. We also have hospitals that are not registered under the AFRH that do not follow these guidelines. Most people make use of guidelines from the American Society or the UK guidelines. Most people make use of that. And Nigeria, one way or the other, most of the fertility clinics make use of those guidelines too. But we must find a way. We are in the process now of trying to create surrogacy, and some of our plea is that let it not just be limited to surrogacy, let it be extended to every single process under surrogacy. Then the second question that I wanted to make a comment on was with regards to known the offsprings from these donations, trying to know where they came from. The good thing is, outside Nigeria, we right now have known donors. So they agree with the commissioning parents that once the baby is born, we want to know the clinic the baby was born in. We want to get all these informations. Is there? It has not really been adopted in Nigeria, you understand, because in Nigeria, due to religious values, personal values, cultural values, we have this thing of anonymity. We need to keep it within us and things like that. There are some families that even their family does not know that the woman gave birth through surrogacy and things like that. And we respect everybody's views. You can have that. But I think with having a very comprehensive regulation that will provide guidelines. The good thing is these guidelines have come up. The National Health Act that came out in 2014 had given, I think, maybe like 2 or 3 sections, sir, regarding what to do with garments, including wills, how you can donate your garment in a will and things like that. But we need something comprehensive that will regulate garment, donations, surrogacy, and so on and so forth. So I just felt I should quickly give this comment. Unfortunately, I have to take my leave right now, but I hope it will help us one way or the other. Thank you.
Barrister Halita Adekule, very valid recommendations there. I'm sure that the profs in the house are taking note. Dr. Ogbise Francis, a facilitator, wants to ask a question. So,
Yes, thank you very much. Something brought up this question, so it's for everybody. When she was talking about the Bible and the gynecologist was speaking about the single women. Now, let me put this question, and I want to see how we're going to answer this because it's important. Now, a woman that is married, maybe for many years, and has been trying IVF, everything has failed, and she gets to 50 or maybe above 54, and the husband dies, how do we handle that case? Because some people are thinking that maybe they see, but now something happened to her husband and she needs a kid. So is she allowed to have kid? So is she allowed to have it done? Because you're talking about Bible, religion, ethics, morals. So where do we stand there? I mean, it just came to my mind. No, she's widowed now. Yeah. No, okay, so where do we place that? That's why I'm asking this question, because now is it the same with the one that is single, the same age, but cannot do it because she's single. But now she's married and now she's widowed. Can she do it?
So the question is, what is the ethical consideration with regards to this? Prof. Prof.
Like I mentioned initially, we have secular ethics, we have religious ethics, but over time, there were attempts to fuse them. The good thing from religion has been incorporated into that secular ethics. And like I mentioned to you, that bioethics is like a melting pot of philosophy, law, religion, and biosciences. That is what is known as bioethics. I don't think ethically there's nothing wrong. But you know the faith you belongs to. That's why I mentioned Islam, for instance. Islam, they are what they call fatwa, because I have to dig down. The schools, the law, what do they call jurisprudence? There are 4 schools of law, and their opinion is that once you cannot say, okay, when you want to do garment donation, it has to be within marriage bond. But it's not only Muslim that are existing in this world, in this earthly surface. If you are a Muslim, you must stick to it. But if you are not, and your religion does not prohibit it, ethically, you are free to do it. You have Christian, Jehovah Witnesses, are they not Christian? They are Christian. Christians receive blood donation, but Jehovah Witnesses, no. So if you are Jehovah Witness, you can't take blood transfusion. And what Nigeria is just trying to do now is that they make it plain to everybody that, okay, you have freedom to do this, freedom to do that. You are getting what I'm saying. So if you are a single lady, for whatever reason, for whatever cause, you now decide to walk into assisted reproductive facility and say you need sperm. But what the only grounds ethics asks is that when that baby is born and grow up and now say, who is my father? You hold that baby duty to explain. That's the position of ethics. You hold that baby because it's the right of that baby to know who his father is. When you see ethicists raising eyebrow about, it's possible now to have chili parents. It's possible now. Technology or science has gone to that level. After fertilization, you have the zygote, isn't it? At that stage, if there is certain genetic, if that child will develop, you can go there, do some manipulation. Maybe the 2 parents, they are carrying that gene. Then you cannot look for third party. It's possible. But when you baby, you should be able to face it. When that child say, "Who are my parents?" To be able to answer. Because that child ethically has right to know who is his or her parents. I don't know whether I answered you. Thank you.
Thank you.
Wow, with medical advancement and all.
Thank you.
So let's have Prof.
Yes, it's as if I would not be able to answer my question, but now I'm able to do that. I just want to say that the reason why you have a registry is that for fireworks, I know the lawyer was talking about having groups. If you have WhatsApp groups or whatever groups, people are going to hack into it. So a registry is a formidable data, that cannot be easily hacked. So that's why I thank Dr. James for the plans to have data, the tracking, which is going to be more authentic than having groups. Age of transplantation. Science has evolved, as Prof said. In fact, right now we can do transplant in utero. So if we do, in the past, when you want to check the genotype of a child, you take a needle through the abdomen and assess blood of the fetus. Science have changed. We don't do that much again. We just take the mother's blood, and from there we can read all the genetic makeup that the child the mother is carrying. So whether he has Fanconi syndrome or any genetic problems, we can identify that. And treatment can also be done in utero. Take stem cells, manipulate it, we can transfuse baby inside the womb. So those are all techniques. So for the age, you can do transplant even from in utero. But for sickle cell, for example, because it's a chronic disease, we usually recommend that you start doing transplant for maybe about 3 years and above, where the child can be a little independent. Because if you have a 1-year-old child who's still sucking or less than that, it becomes very difficult. But if there's an emergency, you can do transplant at any age. Then for adults, there are 2 techniques of doing bone marrow transplant, especially for sickle cell. There's the chemotherapy and then there's radiotherapy. In fact, right now we're moving away from chemotherapy to be using radiotherapy-based conditioning. So for adult sickle cell, in Nigeria, we can only do transplant now for people who are less than 20. Because we're using chemotherapy-based conditioning. When we start with AMC and we'll be able to do total body radiation, there's a protocol for adult sickle cell. So up to the age of 45, transplant can be done for sickle cell. Why we are worried about adult sickle cells is that by the time they grow older, don't forget that after 9-10 years, some sickle cell will lose their spleen. They become asplenic. And then once you are getting above 20-30, renal decompensation, liver problems, you have a lot of problems, iron overload. So we try to avoid doing transplant for adult sickle cell, but there's a protocol that you can use to do for those who are above 20 to 45. And from next year, most likely, when we have facilities that can do total body radiation at AMC, we should be able to start doing for adult sickle cell. Thank you very much.
Thank you so much, Prof. Hi. Well, now we're waiting for time. Is Prof supposed to respond to your question? Okay, so there's a revolution going on there. You did not respond to
what was his question?
The nephrologist. She asked a question. Yes, she asked the question. Maybe I'll just pass the mic on again so you take.
So my question was about people coming in to Nigeria to either get donors from Nigeria or coming in with their own donors into Nigeria to get transplants done. Thank you.
Okay, yes. For bone marrow or stem cell transplants, in fact, because this country, we don't have laws, we don't have guidelines, we don't have regulations. There are people who come even from India. Is it a chance that they can take out of the country? And then sometimes we also try to get donors for patients abroad. We have a black person. I mentioned the person who set up the registry in Enugu, that it was a Nigerian who didn't get. So it's been ongoing, but this regulation is going to try to curtail some of that. The one that talked about the National Health Act, I talked about if you take samples out, you need to also follow due process to send samples out. For example, in Nigeria, we hardly can do a good HLA typing. It's only recently we're having people doing HIV. So the essence is that there will be rules and regulations on how this can be done. And that's why we're setting up these guidelines, so that people would not just come to Nigeria. Is like a dumping ground. People can come in anytime. If our physicians come to Nigeria to work, when I was going to do a program in Switzerland, I had to get certified to even touch their patient. But here, people can come into this country and they are working in one hospital. White skin does not signify intelligence. That's the truth about it. Thank you very much.
Thank you very much. Do I have the floor? Yeah, so my
Thank
question
you.
is also to Professor Bazwai.
Transplant tourism. White man bringing donor from coming to get donor here and have transplant here. He bring the donor. No. No, he bring the donor with him. No, you know, like I mentioned initially, Declaration of Istanbul has outlawed all those kind of transplantation. In fact, during our meeting, during the meeting for this standard, Dr. Bamigboye of St. Nicholas Hospital specifically told me that he was among Nigerian delegates that participated in that Declaration of Istanbul. He told me that there were two, and truly speaking, when I was going through the document, you know, they listed participatory countries. That time, when I was running through it, we have not started this committee work. I saw two Nigerian names. In fact, there were about 150 participants in that declaration from 79 countries. All of them, they are stakeholders in transplantation. So they outlaw cross-border transplantation. If you try to read it, it's very, very useful document. Their reasoning is that every jurisdiction have what it takes to provide its own transplantation. You want to use cornea. All of us here, we have cornea. People die in Nigeria as they die in US. Why should we now be shipping down cornea from US? We are talking of bad exchange rate in the country. When you change naira, because you are buying in dollar, that is the blunt truth. Those are little way we are like messing up our economy that we don't know. Because everything, you want to buy paracetamol, you have to ship it down. I know it also come to human tissue. You now have to go to Sri Lanka.
and came to the hospital with abdominal pains. And my resident that saw thought the person that did this, they've never seen this before. They were already planning to go in and operate, only for a senior radiologist to scan. And then we asked the lady, have you been to a stimulation protocol before? Initially, she denied all of this. And eventually, we put it straight to her, Madam, this is from IVF stimulation. It's not normal. Before she now said, well, yes. She will have lost the 2 ovaries if nobody thought beyond the books to know that this is what you get with IVF stimulation protocol. So it is really difficult sometimes to track these people. A lot of them will not be honest with you, but SOGON and AFRH, I'm very aware that it will be good if you can liaise with them. There's a register that they're trying to develop now. I'm not quite certain what state that is, but it will be helpful, especially with AFRH that kind of has a register of most IVF centers in Nigeria. Thank you very much.
Okay. My name is Dr. Mokudu. I'm a consultant urologist with National Hospital. My question goes to Professor Abubakar. You mentioned prohibition of movement of garment outside the country. So I'll give you a scenario. I know a widow who lost the husband to prostate cancer. And now while he was on treatment at India, he had some sperm banking. So what does the regulation say to situations like that? The man is late, he's got some sperm somewhere, and the wife wants to have more children because she is insisting that she wants to have children for just one man. Then secondly, the sperm is stored somewhere in India. So what again does the regulation say with regards to movement of such sperm into Nigeria for fertilization? Thank you.
Thank you. Is there any other question? Prof says no more because we are racing against time. Yes.
Okay, the sperm is frozen. Is frozen is in India. Eh? The woman is in Nigeria. And then it is the woman can go to India, do assisted reproductive technology after conception, since it is her husband, and come back to Nigeria. I know, but when you look at part 6 of Nigeria Health Act, if you import or export zygotes, embryo, you import, maybe in the test tube or wherever you preserve it, and you are convicted, it's 5 years in prison, no option of fine. It's there like that. But that woman can still conceive. She can go there, do in vitro this thing, and then come back after it's conceived.
I'm sorry, we have to stop there. We still have the keynote address. We've not said it. The people, Clarion Call has not spoken. And there's still a topic on cornea, ITU transplantation. Okay. So I know if we go on like this, I'm happy you are all interested, but I'm sure you are getting tired too. But you are not. Okay. After they've given this series of lecture, we still have time for people to talk. Okay? You don't mind? So, Prof, please, we'll shorten your something. 10 minutes at the most.
Okay.
Okay?
So at this hour, I just want to appreciate every stakeholder here. I want to thank you for your patience, your time, for engaging us, and just being the most amazing audience. And I say this not to flatter you, I mean it from the bottom of my heart. Thank you very much. So at this hour, we're going now straight to the keynote address. And to give us a keynote address is a man of great repute, a man who's paid his dues, a very respected and distinguished professor Aliyu Abdul. He's a professor of medicine at the Bayero University, Kano, and consultant nephrologist at Aminu Kano Teaching Hospital. And he'll be talking on the imperative of updated transplantation guidelines for Nigeria. Please give it up for Professor Aliyu Abdul. Thank you so much, Prof. Thank you.
Thank you very much for the kind introduction. Can you please put on my slides? Actually, the objective of this keynote talk is to introduce us to the guideline and also talk a few words about protecting the life organ donor and also say a word or two about organ trafficking that is coming up in Nigeria. We have had some real live talks about this menace happening in our environment. So we need to talk about it, no matter how bad it is, but we know that it is happening. So we have to do something about it. So next slide, please. I wish I can control my slide. Okay, I mentioned this objective of this talk. Next slide, please. And this is the outline of the talk. Introduction, talk about the guidelines. And since there are a lot of talks about individual chapters in the guidelines, I will just take the last chapter, which the general chapter in the guidelines, and say a word or two about it. Then talk about protection of live organ donors and also about trafficking and its prevention. Next slide, please. So as an introduction, okay, I got this from the forward made by the Honorable Minister of State for Health, the booklet. So he said the federal government is looking at this in two fronts, involving experts in the field and also increase awareness of Nigerians. But I feel it's not enough. We need to have to think about implementation of the provision of the guidelines. I will tell you that the National Tertiary Health Institution Standard Committee under Prof. Abiodun did a lot of work on developing this guideline. He set up all the experts in the field of transplantation in Nigeria, those that have experiences in practice in Nigeria and outside Nigeria, spend weeks of meetings, split into different groups, and develop this guideline. So in terms of engaging the expert in the fields is fulfilled. Increasing awareness is part of what we are doing now. I'm sure anybody that lived this one-day seminar will be more informed about the guidelines. And then we expect you to be our ambassador in disseminating the information about the guidelines. The next one is to call on the government. Now, find a way of implementing the guidelines. Is it through committee to monitor? Sir, you have not finished your work. You develop the guidelines. You have to now see to its implementation. How do we implement this? So we'll need people here to contribute on what to do about implementation. Certainly one way is to guidelines subjected to legislative process, and at the end of the day, have a legal document, a document that is legally backed, so that people know that if you do these things, you cross the road and there are punishments associated with it. And of course, we, the stakeholders, we have to adhere to the prescriptions and the guidelines. Otherwise, the whole thing becomes a talk of the day, and then that's the end. Next slide, please. So what happened? The committee under proper building set up this Nigerian organ donation and transplantation panel. As I said, experts from different fields of transplantation, and give them all this range of term of reference. Initially, when the first meeting was called, I look at the list. I say, wow, we know of committees set up with 1, 2 agendas, but this one, different. But the chairman of the committee, Arogundadi, if you know Fatu, you know the type of person he is. He's very aggressive. And the people that are involved in the panel So developed a way in which the work can be made easier. And that's why this issue of split up committees came in. And that's why these were able to fulfill most of the term of the preference of the committee. Next slide, please. So what are the guidelines? There are 7 chapters in the guideline. Ethical guidelines for organ donation and transplantation in Nigeria, the guideline for establishing and coordinating kidney transplant services in Nigeria, and then the guideline for eye tissue donation and transplantation in Nigeria, and then draft policy guideline on stem cell, which Professor Bazawi talked about, and then draft policy network, draft policy framework for liver transplantation, which Dr. Francis talked about, and also the gamete and embryo donation and storage and surrogacy chapter, and then chapter on gender constellation. Since experts have already talked about other chapters, I will skip all of them and just mention a word or two on the general consideration chapter. Next slide, please. So if you take each of the chapters, I'm sure you have heard the presentation about each of the chapters. People talk about the content, how the chapters were arranged. Chapters start with introduction about the topic the chapter is addressing, talk about guidelines, the facility itself. How do you know that this facility is fit for this type of organ transplantation or this tissue transplantation? What are the requirements in terms of human resources and even the human resources the needed skill sets for each individual professionals involved in transplantation in the center? Then what are the required things, laboratory, other facilities required in each of, to perform this type of organ transplantation? And also the chapter and also include recommendations. For all involved in organ harvesting and transplantation in Nigeria. And then this certification should be renewable every 5 years. The need for updating our knowledge on the current issues about transplantation. And also the participation should be open not only to healthcare professionals, the lawyers. I'm happy a lawyer was here and has made comments. And then law students, social workers, other interested members. I'm sure Proper Boydin is looking note of this one. Next one we are doing will be richer than this in terms of the people involved. And resource persons should include ethicists. Prof. Abubakar is an ethicist. I don't know whether I can call myself an ethicist because I'm the chair of the health research ethics of my university. Ethicists, health law experts, social worker, religious expert, and so on should be included. And the module delivery should be physical and online, as we are doing today. People are following us online. And then the venue should be in Abuja, and we are doing in Abuja. But I'm just asking Prof, next time it should be moved to other part of the country so that more people will be given the chance to know about these guidelines. So what I'm doing now is trying to practicalize the recommendations of the guideline. Next slide, please. So I'll not look at it. Already, I promise you that I won't touch other chapters. Professor Way has done wonderfully well about tissue, about stem cells. And then Professor Boko talk about gamete, Francis talk about liver and kidney and so on. So other chapters have been talked. But the general chapter of the guideline talk about 2 or 3 things: hospital transplantation committee, ensuring adherence to established guidelines in Nigerian healthcare system related to organ transplantation, and also addresses the National Organ Donation and Transplantation Registry. People talk about this registry a lot. But the guidelines specifically talk about the establishment of the registry. Next slide, please. So this hospital-based independent transplantation committee, I don't know how many centers that are doing transplant have this type of committee. If you know your center has independent transplant committee, can you please raise up your hand? If you know your center, independent transplant committee, which center is that?
Caroline's.
Caroline.
Federal Medical Center, Abuja, yeah.
Federal Medical Center, okay, JB. Okay, great. So 2 centers. Any other center? So, so probably have a lot of work to do. So the part 4, section 51 of the 2024 National Health Act, it has been quoted a lot today, provide for the establishment of independent tissue transplantation committee to superintend transplantation activity in each hospital. So by not having the committee, you are not only violating the guideline, but you are also going against the laws of the Federal Republic of Nigeria. And the committee, the guidelines in line with the National Health Act specifically mention the composition of the committee. The CMD or his representative, the CMD or his representative should be minimum 5 years post-fellowship experience. So not a young consultant, should not be involved in transplant process at all. So no member of the transplant team should be a member of the independent committee. And then the hospital lawyer it has been mentioned earlier today, transportation, missed work hours, and so on. But nothing other than that should involve any financial transaction. And then document indicating adequate education and orientation. That the committee must make sure that the donor knows what he's going for. Dr. Memben mentioned her experience. There's some potential donors, when you see them, you know that they don't know what they are going in. So the committee should make sure, and this guideline, as we see, stipulated mandatory education of the donor. And there must be a documented evidence that this enlightenment of the donor has taken place before the donation process goes on. So it's the work of this committee now to make sure that that process has been done. And then finally, okay, now give the directive, yes, this transplant should go ahead. It has satisfied the minimum requirement for this hospital to undergo transplant. Next slide, please. Okay, then enough of the committee. Then the other aspect I promised to talk on the general chapter is the National Organ Tissue Donation and Transplantation Registry. The aim is to enhance the management oversight and oversight organ transplantation across the country, and then accurate record keeping to maintain comprehensive record of all organ donation and transplants throughout the country. This is for medical legal issues and any other related issues that may come up as the result of the transplantation process. And then ensure transparency in the allocation of organ. This, when we start, become relevant when we start cadaveric organ donation in the country. Then also it allows for research activities to go on. We'll be able to look at the data and say transplant in Nigeria is to the best international standard. Maybe the mortality rate, whatever we are calculating 1 year, 5 year, and then the outcome and other related issues are as good as anywhere in the world, or otherwise, they may call for review of the whole process. And also public health promotion, because by the time we are seeing good record of the organ donation process, it will encourage more people to become potential donors. It's very important. Next slide, please. There are recommendations for the establishment and operation of this registry, but we need this legislative support. And this will only come after the amendment of this act. This National Health Act, as we can see later, people have criticized it severally. And it needs collaboration with healthcare providers. Okay. People tend to hide data. There's nothing wrong being open. In fact, it gives people more confidence in the system you are doing. Whether the result is good or bad, please open up and then share your information, share your data. Your data may be a source of learning process. People may learn from your mistakes, or people may learn from the other side of the work you are doing. And then awareness and campaigns. Okay, thanks to Clarion Call, this, what we are doing is making people to know about all these guidelines. Okay, next slide, please. So this is about the guideline. So I summarize what the guideline contain, and I promise that I will say a word on protecting the live organ donor. The protection of the live organ encompasses moral, legal, and pragmatic safeguards to guarantee their autonomy, well-informed choices, and well-being. Most importantly, before the donation process, during the donation process, and following the post-donation. It's very, very important. This post-donation follow-up is what we normally neglect. In most instances, after the donation, the donor is lost, follow-up, nothing follow-up. And it's not only in Nigeria. I'm happy that you raised that issue earlier on. We have to do something about it. The donor also need legal protection against coercion, against, need medical monitoring, and then potential long-term health support and financial assistance for related costs like loss of wages and so on, and then medical care. In some countries like US, they have programs like Donor Shield. If you are an organ donor, they honor you with a shield. It's called it Donor Shield, which offers comprehensive support for kidney and live donors, providing safety net and making donations process more accessible. When you see people are honored because of what they did, it encourages others to do the same or even more. So that's why this issue of things like this organ shield and so on, donor shield. Next, please. Okay. So ethical and legal frameworks for protecting a potential live donor involves voluntary and informed consent. The WHO said that live donation must be free and informed decision by a person who is not under duress or under influence and who is aware of the risks and advantages of the practice. That's why this issue of patient education, awareness, enlightenment of the donor is very, very important. And this aspect has been highlighted in the guidelines. I'm happy Prof said that the guideline will be shared and the guideline contains all this. Also, the donor needs protection from exploitation. Okay, it happened. Okay, there should be specific rules and regulation to prevent exploitation and ensure that donors are not under any pressure. Okay, it's very, very important. And then prohibition of organ sales. Okay? We can copy from US. The US, they have a law they call National Organ Transplant Act of 1984, which makes it illegal to buy or sell human organs for valuable consideration. The act also allows for creation of organ procurement and transplantation network to oversee organ distribution. So we can see where we differ from them. They make a law and they set up mechanism to follow up the implementation of the law. We need to do that for these guidelines. These guidelines need to be made into law, and there should be a mechanism to follow up with implementation. Like I was discussing with Prof, we have to set up mechanism to ensure follow-up of this guideline. Things like accreditation. We need to have a process where we can send experts to hospital where they do transplantation to make sure that do they have what it takes to offer transplantation or not. And we should be honest to ourselves. Next slide, please. So from when I saw you standing, I thought you were going to tell me it's time. Okay. The potential donor also need medical and health protection. This pre-donation evaluation I mentioned is very important. Thorough what makes them to donate. It's a poor follow-up when it is less than 25%. So that's what we did. We now analyze the 16-year data, and let me share the result with you. Next slide. They have done more than 1,000. These are only live donors because South Africa will also do cadaveric. And most of the time, the cadaveric takes a larger number of the transfer. But about 60%, okay, they either withdrew or were withdrawn from the donation process. So you can see if you are diligently following the rules, you see that not everybody that come to say, I want to donate, will eventually end up as a organ donor. And then this reason for non-donation can be, we find some are medical, some are non-medical. Okay? And among the non-medical, then voluntary withdrawal. But the medical causes, renal cares, were the commonest causes. So the person, the potential donor, does not even know that he has a kidney problem. It's through the process of evaluation that is found out that he also may eventually need a kidney. So it's because of the pre-donation evaluation is excellent. That's why this type of people are identified before the transplantation. So the one I highlighted was the follow-up, post-donation follow-up visit. You can see it was only excellent in about 30%. Only 30% have this excellent yearly visit. That even if you are well, you have to come to the hospital once in a year for checkup. And this checkup is free in that country. But even at that, only about 30% were able to get that. It's adequate in 34%, and then majority 30% was unacceptable or very poor follow-up. So next slide. Okay, so another protection the donor need is this financial and practical support. Okay, coverage, of course, it has been discussed. Protection against discrimination. Okay, this act in US, okay, protect the donor from any form of discrimination, especially this insurance company. They say this guy has one kidney, he has high risk of kidney disease later on, therefore his premium the cost of those hours that you are going to lose should be covered. Next slide. They also need emotional and psychological support. Live donor, because the psychological benefit are for both the donor and the recipient. And then a donor candidate is psychologically fit to donate. This must be ascertained before the donation process takes place. And then it should be informed that donors, they have good quality of life after donation. Although some people may experience psychological difficulties, especially when they now lost the recipient. You have to do a lot of psychological work. Now he lost his kidney, and then he lost the patient that he has donated the kidneys for. Next slide, please. So in this guideline, what do we put in place to protect the donor? So this guideline, okay, emphasizes define who can donate. Dr. Francis has mentioned that one. Either genetically related, emotionally related, or through a paired exchange or crossover donation. There are pre-donation guide. This orientation, I mentioned the donor need to be oriented, and this orientation need to be documented and signed. It's evident that and then at what age the transplantation should be allowed. The committee, the independent transplant committee of the hospital, need to go through all the document because it's been mentioned in the 2024 National Health Act. So it become a legal process. Then, okay, it's important to also do a survey, okay? Then protocol for kidney donation, each hospital should have its own protocol and make sure that those protocols are followed. That's why this guideline is silent about this, when, how frequent post-donation follow-up take place. It gives leverage for the centers to develop in its own protocol. But this mandatory once in a year follow-up is there. Okay, and then a lot of things, live donor checklist. So this guideline is trying to protect the potential organ donor. Next slide, please. Then the guideline also talk about post-donation guide immediate post-donation care, financing of donor medical care, and follow-up care, the frequent clinic visit, and then the role of the transplant coordinator. Okay, if you look at the guideline, we all mention it clearly so that the donor is well protected. Next slide, please. So, okay, the guideline also talk about the ethics of organ procurement. These are all in protection of the potential organ donor. It's unethical to sell or buy human parts or commodities. It's even against the rule. So the guidelines stated it clearly. Okay. So next slide, please. So I also want to mention a word or two about organ trafficking. Okay. It's clearly defined by WHO: recruitment, transportation, transfer, harboring, receipt of living or deceased organ persons or their organs by means of threat, use of force, or other forms of coercion or deception for the purpose of organ removal and transplantation. It's clearly defined. So if you are not careful, you can easily fall into this law. Even assisting, even accommodating the person that's coming for organ trafficking, you can be complicit in by this definition. Of course, kidneys are the most commonly trafficked organs illegally. According to WHO, about 10,000 kidneys are sold on black market globally each year, with one being traded every hour. So it's a serious international crime. It involves criminal underworld by an organized network of illegal brokers and agents that supply organs for victim to recipient. So they told us now even they exist in Abuja, these organ brokers, ranging from those called organ hunters to those who work full-time in medical industry. And you'll be surprised the people that are involved in this dirty business. Physicians are involved, nurses, anesthetists, even ambulance drivers. In fact, I was discussing with the Link that she even suspected the people that work in the lab, that they can connive with them and into this type of business. Next slide, please. And you will not be surprised. It's a very lucrative business. As this document showed the range of money involved in this organ sale. Okay? As much as 150,000 US dollars for a lung. As much of, okay? The kidneys, as much of 62,000. Calculate this in Naira and see. It's a real business. It's tempting. Okay, the amount of money involved. Next slide, please. And as mentioned, it's world over. Okay? It's an international crime estimated to generate 600 million and 1.2 billion in profits per year. This is the source. So it's a serious business. Next slide, please. And these are countries where there are documented cases of organ trafficking. Documented, legally processed, documented. And this is my source. I will give it to you in terms of, because of time, I will not go through them. And you can see the countries involved. Developed countries and developing countries. So I have to be very careful in Nigeria. Next slide, please. This is a famous picture, okay? One village in India. Almost 1 in 3 5 adults, his organ has been removed. Okay? Trafficking, no? Next slide, please. Is it in Nigeria? Yes, I Googled. These are the sources that talk about organ trafficking in Nigeria. We live with it. It's real. Okay? And then I was even scared by this data. Okay? That from 2015 to 2020, 651 kidneys were illegally transplanted in Nigeria. So it's with us. There are BBC reports, okay? News, papers, everywhere is there. So it's a live thing you have to tackle with. Next slide, please. So why do you think organ trafficking may flourish in Nigeria? It's happening, but up to now, people are not talking about it. I don't know. because there has not been any prosecution. I don't know why we are hiding it. I don't know. But there are reasons, okay? Poverty, inequality, and ethical medical practices, lack of regulation, and enforcement. But I would not agree with lack of regulation. It's more of enforcement. And then medical ethics is neglected. Okay? Okay, no conscience in the medical practitioners themselves. Okay? Because if you follow the oath of your, you take as a nurse episode. I saw the registrar of the physiotherapy council earlier in this hall. Maybe he left. Okay, so as a health worker, if you follow the ethics of your profession, you shouldn't be involved in this thing. And then the victims are mostly impoverished people who are easily influenced by financial incentives, and most of them are ignorant of possible risk involved. Most of the victims are ignorant. And the lack of an alternative organ source. Okay? This Dr. Garba was mentioning, whether I would like it, is elite that are involved. They have money, they have influence, and they need the organ. They'll look for it. On the other side, no alternative source of the organ, and then vulnerable people. So you can see how this business, we have to work hard to fight it. It's with us. Okay? But the unfortunate thing, many of the organ donors are left without proper medical care or financial compensation after the procedure is completed. I saw the interview with this daily trial. I was part of it. Okay. The guys were saying that in past they were promised an amount of money. After the procedure, they didn't get even half of what they were promised. The organ hunter, was the vendors, chop all the money. It's a serious issue. Next slide, please. What are the menace of this commercial organ donation? It's terrible. Clinics are open, they don't have the basic facilities, okay? And then not really qualified. They can qualify in terms of paper, but in terms of this conscience, professional ethics in the clinics where these things are done, it's questionable. And then patients are hospitalized for a short period of time just to lessen the cost. Okay? No proper work-up is done. Okay? No education, no nothing. The recipient have higher incidence, and then what they don't know that even the recipient of this type of thing, they have side effects. Okay? Incident of acute rejection because they are in a rush to do it. Proper matching, proper cross matching, and so on. And then imperial complications and high incidence of surgical complication because the centers, in most instances, they are not qualified enough. They don't have the much needed experiences. Because there's even documented cases of transmission of infection. There's this paper I read, higher incidence of HIV infection in Arab recipients who went for this business, organ donation business in Bombay. Most of these Arab people, when they return with diseases because the source of the organ are these people of the underworld. So donors usually have psychosocial issues post donation, beginning with regrets because the money that they promised to give you, they didn't give you. Or the financial problem that induce your commitment to selling your organ, you cannot solve it even after you sell the organ. Then you start regretting. And then from regret, even severe depression were reported in this type. Slide, please. So what is the way forward? Okay, we need a comprehensive legislation which specifically deal with organ trafficking, such as a codified Nigerian law on organ transplantation. So these are guidelines. It's just a beginning. We have a lot of work to do. Okay, this National Health Act. Okay, so the NAPTIP people, we have a National Health Act that talk about it specifically. Okay, it has been criticized as being too big. We just mentioned that, the whole organ, when they are doing public hearings, our association, Nigerian Association of Nephrology, we raised issue and said, no, 100,000, no, it's too small. Then one of the lawyers say, okay, did you check penal code? When you remove the whole hand, what is the money there? So you cannot put kidney higher than what is already in existence in the laws. So we need a comprehensive review of this law. Okay? We need a regulation of the overall process and establishment of government regulatory body overseeing organ transplant. So your committee, that's why I said we have a lot, you have a lot of work to do, sir. You have done well. Guideline is develop implementation, sir. Implementation. Do we need that's why how I wish the permanent secretary is here. We need a body that regulates this thing. Otherwise, just talk and then watch
remove this corneal tissue and then replace it with something that is transparent so that the light can enter. So we do corneal grafting or corneal transplantation. So next, general principle. Just like I mentioned in the morning, when we say eye tissue, it refers to cornea, sclera, conjunctiva, whole globe, and then amniotic membrane. Everybody know where we get amniotic membrane. Next. So there should be tissue registry, just like we have in other body parts, where we document or coordinate the waiting list, and promote it transparent. Next one, the eye tissue bank. After harvesting the eye tissue, we put it in preservative. Ideally, they are supposed to be central one, controlled by federal government, then maybe 6 geopolitical zone or state one, and the facility one. Next, then facility for eye tissue transplant. Whenever anybody is going to set up facility for eye transplant, it should be registered and should be accredited. Then there should be transplant committee. Then there must be trained surgeon. You can call them corneal transplant surgeon. Then there should be ethics oversight. Then there should be instructional material. They should be using it from time to time to improve their service. Next one. Then there should be voluntary informed consent before you remove the eye from deceased donor, because most of the cornea are affected from deceased donor. Then there must be ethical procurement and utilization. Then you must prioritize the safety of the recipient. Then there should be prohibition of misuse of donor tissue, because Nigeria, we are a community where you have a lot of superstitious belief. Somebody may say he needs corneal tissue to make juju for money. Legal consideration. So national tertiary institution standard committee, it has to be comply. Whatever we want to do, there must be informed consent. Then before a disease is certified, there must be 2 qualified doctors to certify. And in Nigeria, death is defined as irreversible loss, total loss of brain function. We have cognitive function and then autonomic function. All of them, they must have disappeared before we certify patient dead. And then immediately, the affecting team, they have to swing into action. Because within 6 hours, under room temperature, if that eye is not affected and then put under preservative, the tissue may get devitalized. Then, like any other tissue, there's prohibition in cells of eye tissue. Then donation has to be altruistic, that is for charity. So you can't profiteer from eye tissue, just like any other. Next one. Next one. Next slide. Okay. Like we mentioned, there's no profiteering from eye tissue. Then we have few functional eye banks across the country. Most of them, they are private driven. Then reliance on eye tissue from foreign clime persists. So we have eye here. We have dead body here. I don't know why we should continue to get eye tissue from elsewhere. So though the advocacy efforts are ongoing. Next one. Next one. Okay, governance and coordination. Uh, Ministry of Health and Social Welfare leads, and then IPANC Society of Nigeria oversees it. Then there's collaboration with National Health Research Ethics Committee, MDCN, and Ophthalmological Society of Nigeria. Then we need National IT Issue Registry so that there will be coordination. We will know whether a particular IT issue is available or not. Next one, licensing and accreditation. Eye facility providing eye transplantation service, they may be registered as eye bank, corner transplant center, or ophthalmic unit. So, and that license is renewable every 3 years. Next. Next. Okay, just like I mentioned, within 6 to 12 hours of demise of the donor, that corneal tissue or eye tissue has to be retrieved and then quickly put either in what we call media. Media, there are special no allocation based on man, no man. Political status or wealth. Next, political status or wealth. Next, Nigeria has codified and launched standards and guidelines on eye tissue donation, harvesting, retrieval, banking, transplantation, and registry for Nigeria. Stakeholders have individual and collective roles in getting acquainted and ensuring compliance to ethical eye tissue donation and transplantation in Nigeria. Thank you.
Wow, Professor Abubakar, we cannot thank you enough. It's been a full day, a full day. And just tap in, tap in. Please, can we have the light on? Tap in from your bank, your knowledge bank, so rich. We are enriched by your bank of knowledge, and we are so thankful for your time today. At this hour, I'd like to say we've had a successful seminar. Yeah, true? So can we please celebrate that? At this hour, before we proceed downstairs for the presentation and launch, may I respectfully invite a man revered, loved, respected for his impact globally. He has raised men in the medical practice, men that I'm sure he's so proud of. In Nigeria, we are proud of his strides, his impact, the legacy that he is building. Very distinguished ladies and gentlemen, please permit me to make welcome on stage, just takes a podium, the co-host of this very successful event. It's no other than the chairman of the National Tertiary Health Institution Standards Committee, Professor Phillips Abiodun, a father, a mentor, a leader, an inspiration. And permit me to brag again. Unibest. Unibest. Thank you so much, Prof.
Well, ladies and gentlemen, happy to welcome you at the end of the meeting. Supposed to be a welcome address. That's why I say I'm welcoming you at the end of the meeting. The National Tertiary Health Institution Standards Committee is supposed to regulate organ donation and transplantation in the country. And that is why we are here. All the things that we have said at the beginning have been said by different members. Why we are here, why a committee is needed, and all this and that. It's in National Tertiary Health, National Health Act of 2014. And with all the speeches you have had here, there's no doubt. Can we have one room, please? There's no doubt after hearing all the speeches here. I hope you see okay. Now, after all the speeches here, I don't need now to tell you why we are here. Now, there are some members of the National Tertiary Health Institutions Standards Committee here. Can I see you, please? If there are some here. Are there some here? Mamu Rufai, members of the registry. Adebayo, Larewaju, Gbemi, where are they? Can you please stand up for recognition? So please clap for them. They are all the people who have made it possible for this meeting to hold. Are there members of those who participated in bringing up the guidelines? Please stand up for recognition. There they are. So these are the people who made this document possible. And we didn't pay them. But with your clapping now, you have paid for them again. So I think our job is now for you. It's now for you. Everybody has said we still have a lot to do. We still have a lot to do, but I can do nothing without you. So if you disseminate this information, Dr. Adebayo, please, if they have their numbers or emails here, you don't have. We send you soft copies of these documents. I thought you would clap for that. So that everybody will have a copy of it. We cannot print more copies. As usual, no money, no money, no money. Adebayo is going to use his money to send to you as if it's free of charge. So, but he will do it to make sure that. So, your job is to please go through it and make sure that what is here is followed. Is that all right? Now, Dr. James, Dr. Obi, please come forward. Panitri, please come. This meeting, we say we want dissemination, dissemination, dissemination. These are the people who have made this meeting possible today. Once they heard of us, they contacted us and said we shall partner with you. And they are now, you can see that they partnered with us. The whole, the everything, you're being here, the food you are going to eat is not from me. They made it possible. And they come all the way from the United States of America. They are members of the Clarion Call. So they've called all the way from America. Clarion Call from America. For our people in Nigeria to wake up and let us make sure that we succeed with these guidelines. So it's very impressive, and I'm very proud of them. And since they've been here, we've been working, all the things we have been discussing about the registry, they are going to work with us. Yesterday, we had a virtual meeting with their partners in the US who said they will give us a software to make the registry possible. Now they've agreed with us that this dissemination, as you have said, is not only going to take place here, but in 4 or 5 more geopolitical places in the country. So January, I think you're going to say what? January 29, we're going to be in Maiduguri with their support. So I want to appreciate them publicly because they've encouraged us a lot, and they continue to encourage us. And so I appreciate you. I want to say thank you. So when you say people have jackpot to Nigeria, so return jackpot. And I want to thank them immensely. I want to thank all the speakers, to Abdul, Bazwaye, Ayani, and each and every one of you. It's not supposed to be a thank you. As I said, it's supposed to be welcome, but I'm welcoming you into the group. That's a welcome, isn't it? To make sure we do the propagation. You set up your committees in your teaching hospitals. Make sure you follow the guidelines, read through this very well. Don't participate in any illegal something. Don't condone it. Then you will have done a lot to have supported us and yourselves. I think that is the most important. Those are the most important things I want to say. You know anybody who can help us financially, registry, banking, please let us know. Because as you see now, the government wants us to do it, but they've not brought much money for us. So, but we are all government. It is for us. I was happy when I got to one state and the governor was supporting federal teaching hospitals. He said, "There's nothing federal in my state. Is it not my people they are taking care of? He said, they are federal human beings. They are people of my state." He built, gave computers, MRI, everything to the federal teaching hospital. So when some say they are federal roads and they neglect them, is there any federal going through that road? It's for your people. So I was very impressed and all that. So I think we have to also work from that principle. So as I've said, our next meeting is going to be in Maiduguri, January 29th. But you have a job today. Make sure you become disciples. Make sure you get the guidelines further on and on and on and on. Make sure no illegal practices in your own institution. We are starting with the registry now. Dr. Adebayo, we are collecting names of all those who say they are doing transplantation. I met with the Transplant Society of Nigeria. I met with the CMDs. All of them are all aware that we are starting with our registry now. So you have to make contact. Where is Adebayo? I hope he's still there. Dr. Adebayo, you know. So please stand up on your table for recognition so that they can see you well. So it's the desk officer for us. So we're collecting that. I would like you to say one or two words to us. Thank you.
Okay. Thank you, Professor Abiodu, for always putting me on the spot. But we're very excited to collaborate in this endeavor to provide safer transplantation to our patients and to really protect our donors. It can be done, I think, and it takes all of us to get the job done. So please, like Professor Abiodu said, please study the guidelines. Please make sure that within your centers you are abiding by the guidelines. And even for those who you are suspicious that are illegal, I think even tapping those in and helping to reorient their thinking. I mean, I think this is where we have to start. And I hope that as the registry develops, that we will have a pool of living donors that we can have to serve our patients who are in need of renal replacement. Thank you.
I think people are hungry, so we should go eat.
They are not complaining. And I want to please clap for yourselves. I've hardly had a meeting, I know she will still say it, where almost everybody has stayed till the end. So I think we have sent out some papers for their views as feedback, but I can see that, I mean, you are an impressive group of people. I'm very impressed. I want to thank you all for coming. For downstairs, we have a group photograph here with this background. So let me invite you now. Yeah, pardon? Okay.
Facilitators first.
Okay, facilitators first, please come. Facilitators, please come. Adebayo, join us. Please, let's use this background. All the speakers, please come around. Please come. How do we stand? Obi, come. Obi, Obi, come. We want to use this background. How do we get it into it? Who is the photographer? Okay, I understand in the middle.
Yes, sir. Yes, sir. That feel like this, sir.
Is there still an NTHIC member here? Mamu, Rufai, are they gone?
Thank you, facilitators. Next, we'll have a group photograph with participants. Uh, participants, please. Some people will sit. Some people will sit.